Hi friends, I'm and I'll be helping you to understand the few principles and facts for clearing your NEET super specialty exam. I'll be dealing with the plastic surgery part, both in the general surgery aspect and in the subspecialty aspect. So it is we'll keep it in that particular channel. Okay, so when we are dealing with the general surgery part, I'll be very conscious to keep it to that level, and when we are in the subspecialty part, it will be very clear to go further little deep into it. Okay, so this session is supposed to be a introduction to what to expect from us further. Okay, so in this class, I am giving something for both the general surgery part and for the subspecialty part. Okay, so for example, a particular topic, how we will be dealing it for the general surgery part and for the subspecialty part. And there are few topics which are to be dealt for both of them. Okay. So without much talk, shall we proceed to the, and feel free to ask questions about these topics. Okay. The best part about this method of not cramming all the sessions into within 1 or 2 days, so that you will not have breathing space. The advantage with this is you will have a lot of time for you to assimilate the knowledge which you get. Okay, because it is over a prolonged period of time. Okay. Okay. Shall we go into the topic per se? Okay. If you're having any doubts, you can put it in the chat box. Okay, I'll be very happy to answer it. I'll give you the ideology behind these classes. So we'll go into the topic per se. Okay. So, for example, when we are discussing with the wound healing, okay, this will be the general question. Okay, the true about wound healing are all except. Okay, neutrophils are the predominantly seen in the inflammatory phase. Granular appearance in proliferation phase is due to the extracellular matrix. Type 3 to type 1 collagen conversion happens in the remodeling phase. Increased levels of TGF beta is implicated in hypertrophic scar. Okay, the participants who are all present can ping the answers in the chat box. Whoever is interested, should I wait for any answers? Participants, where can I see the chat box? Yes. Should I wait for any answers?
There is one answer which says 4.
There's one answer which says 4. Okay. I think this wound healing is something which is dear to all of us, but it is a little bit complex. Okay. No, not very complex, but if you go into the molecular levels, it is a little bit complex. This is dealt with both means like you can read about this in Bailey and Lowe, you can read about this in Sabiston, and if you want, you can read little more about it in plastic surgery aspirants, can read it in Elegant. But I'll try it wherever you go, these concepts will not change. Okay, you know this is I have taken it from the Sabiston. You know that there is an inflammatory phase, proliferative phase, and a maturation phase. Okay, in some books they also had the first phase as the coagulation, okay, or hemostasis. Okay, so inflammation phase lasts for 24 to 48 hours. Okay, to after the inflammation phase, proliferation, that is from 3 to 2 weeks. Okay, 48 hours to 2 weeks. After that, you will have that maturation phase. It's not exactly mutually exclusive phases. There is a wide overlap. As you see in inflammation phase, the predominant type of cell type in this will be the neutrophils. In proliferation, it will be the fibroblast. Maturation, there is no particular individual cell type. Okay, if you see this chart, you get lot of information. See, there's type 3 collagen which is first deposited, which is then converted into type 1 collagen. And if you see the wound breaking strength, okay, it slowly increases in the maturation phase. So based on this, now anyone would want to answer this? Anyone will want to correct this, or whoever has answered? As you see now, based on this, you will be able to tell that neutrophils are predominantly seen in the inflammatory phase. Type 3 to type 1 collagen conversion happens in the remodeling phase. But between these two, you will not be able to come to a conclusion. Okay. That is why we need to go a little bit further into that. Okay. So first we will go into the fourth one. Okay. For example, increased level of TGF beta. Okay. Transforming growth factor TGF beta. Okay. So what do you know about this TGF beta? Okay. There are actually three types of TGF beta: type 1, 2, and 3. Type 1 and 3 are implicated in increased hypertrophic scar. So increased level of TGF beta is implicated in hypertrophic scar is true. And the granular appearance in the proliferation phase is not due to the extracellular matrix, it is because of the blood vessels. Okay. And extracellular matrix deposition also happens during the proliferation phase, so you'll be confused there. So I think it might be because of that, but it's not because of that, it is because of the blood vessels. Okay. So as a spin-off from this, what all questions can be asked in this? So what we know, what one thing we should know is what are the cells which are predominant in each phase of the wound? What are the growth factors which are predominant in each phase of the wound? What are the physiological activities which are happening in each phase of the wound? Once we analyze and see in that kind of view, we will be able to answer all the questions. Okay, so cells predominant neutrophils and macrophages come in the inflammatory phase. Fibroblasts are predominant in the proliferative phase. Okay, and there's no particular cell type in the remodeling phase. Okay, so what exactly happens in the inflammatory phase? Chemotaxis, attraction of neutrophils, phagocytosis, all these things happens, and secretion of platelet-derived growth factors and uh, platelet-derived growth factor, heparin binding growth factor, all this happens. So in the proliferation phase, what is happening? In the proliferation phase, there is the conversion of macrophages to fibroblasts and secretion of collagen and the ground substance, extracellular matrix, glycosaminoglycans. So what is the type of collagen which is secreted? Initially, it is the type 3 collagen which is secreted. Okay, so what happens in the remodeling phase? This type 3 is slowly changed to type 1. What also happens in the remodeling phase? This type irregularly, haphazardly deposited collagen changes into linear type of collagen. Okay, so these are all the extra facts which you need to know as in the general surgical part. So if there are any further questions, you will be able to answer that accordingly. Okay, so little bit going into this collagen. Okay, what could be the next one? The main type of collagen in the basement membrane. This is I want to give a spectrum of questions because you will be getting fact-based questions. You will be getting reasoning-based. You will be getting questions based on the concepts. So first one was relatively not exactly a fact-based. You need a little bit understanding. This is a pure fact-based question. This answer is present in Sebastian. I have taken this directly from Sebastian. Okay, any not able to see the chat. Just a minute. From Siva. Good. Good, Dr. Siva. Okay, can you tell me this type 1 collagen as a spin-off from this type 1 collagen, where is it usually present? Because now I have asked type 4, but the question could be type 1 collagen is present. That is present in most of the normal tissue. Okay, in the dermis, in the cartilage, everything. Okay. So the spin-off for this could be the other options. Okay, and if you don't know the other options, it will be difficult. Type 1 is normally present in the normal bone, okay, blood vessels, everything. Type 2 is in cartilage. Type 3, newly formed scar, okay, and internal organs. Type 4, as we have seen in basement membrane. Okay, so these are all pure fact based questions which you need to understand. Next one, nice one. Because there will be a lot of named questions in plastic. Okay. Am I audible to everyone? Is everyone
Yeah,
following?
yeah, you can go ahead. Yes, yes. Okay.
Yeah. Okay. 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 This one, anyone want to take this? Anyone want to take this? Concept of angiosomes was described by. I'm just waiting in the looking for the chat box. Mathison Nahai. Siva says it's Mathison Nahai. Dr. Siva says it's Mathison Nahai. Anybody else? Or anybody else wants to comment? No, it's just a guess. It's not an exam. Anybody wants, you can be actively involved. Dr. Siva, where have you come across this name of Mathison Nahai? Actually, he's a contemporary plastic surgeon. Okay, he expired now. It's not very long back. Okay, Mathis and Ford Nahai. Okay, they gave the classification of muscle flaps. Okay, Cormac and Lamberti, they gave the classification of fasciocutaneous flaps. Okay, N.T. Jackson, work by Salmon and Manchot, who described the concepts of angiosomes. Okay, and you might be specifically put N.T. Jackson because there's Ian Taylor who familiarized this concept of angiosomes, but it was originally described by Salmon and Manchot. Okay, there are so many names which you should know who describe this. Okay, so Indian name, everybody will say father of plastic surgery. It is father of ancient plastic surgery. Okay, if the question is father of plastic surgery, it should be, answer should be, anyone? I think this someone will be interested to tell. Harold Gillies. Okay, father of ancient plastic surgery, then only it will be Shushruta. Okay, these are all few things which you should be very careful. This might be very misleading. You might think that okay, sir, father of plastic surgery. They asked. I know it was Shushruta only. Okay, that thing you should be very careful. So what is this angiosome? Okay, for a general surgery means for other specialty aspirants whom are attending this for the general surgery part, I will stop here. Means like for angiosome concept, it is enough if you know who described it. Okay, and what is the angiosome? It is a unit of tissue which is supplied by a single blood vessel. Okay, this is an angiosome. It's a unit of three-dimensional unit of tissue which is supplied by a single blood vessel. But if you are a plastic surgery aspirant, okay, what will be the applied aspect of this? What all questions you might be getting? Okay, you need to know what is a okay. The applied aspect of this is we need to go a little bit further into this. Okay, if you are a plastic surgery aspirant, you need just knowing what is angiosome, who described this is not enough. Okay, you need to know what is the anatomical territory of a blood vessel or a flap. What is the dynamic territory of a blood vessel or a flap? What is the potential territory? Okay, for example, if you base a flap on this based on this artery, the dynamic territory is the communications between the adjacent angiosome. Okay, parts which are getting perfused through a fluorescent dye injection is called the dynamic territory. So what is the implication of this? When you are raising a flap based on this, you can go up to this dynamic territory. What is this potential territory? This is the communication with the next angiosome. So how to include that? That is a separate topic per se. I will come to this later. So what are these vessels called? The vessels which are plastic surgery aspirants should know. So we will be going detail into that. What are choke vessels? Okay, what are arteriovenous anastomos? What are the different types of arteriovenous anastomos? I don't want to bore you with all those things because I don't know how many plastic surgery aspirants are there now. So I'm just introducing you to the how we will be going ahead. Okay. So the next concept is delay. Anyone aware of this term? I'm sure everybody has undergone this procedure, but whoever is aware of this term delay, just you can raise your hand. Okay. Okay, then we'll go ahead directly to the question. Okay. So what do you think is delay? Sorry. What do you think is delay? True about delay phenomenon are all except, note the question, are all except. It increases the axiality of the blood flow. Maximum effect is seen after 2 weeks. It induces a hyperadrenergic state in the flap. It is done when the patient's general condition is not stable. So unless you know what is the delay phenomenon, this thing totally will be totally out of the blue. Okay, see, actually I'm not able to place this anything. So is it a procedure or it is a fact or what exactly is the delay phenomenon? There are particular areas in plastic where you will be totally introduced to a new phenomenon. Okay, so this is what I wanted to introduce. So any takers for this? Anyone wants to? Dr. Siva, you are the one who are active. Anyone? Just take a guess. It's not an exam. Is there any specific reason why I put this delay phenomenon after the angiosome concept? Okay. Yes, there is a particular reason because what is delay phenomenon? As I have already explained to you, the angiosome, I have explained the potential territory of a flap. Okay, so if you want to include the potential territory of the flap also to include it in the flap, okay, then you have to do the phenomenon of delay. Then it's very simple concept. Okay, it's very simple to understand. Okay, for example, you are practicing for a marathon. Okay, first day you cannot run 42 kilometers or exactly 41.2 kilometers. Okay, what you will do? You will be just running step by step. Okay, or if you want to go for a dieting, okay, suppose you cannot just go from totally you have been taking, for example, you have been taking 5 rotis or something like that. Suddenly you cannot go to one. You will feel very hungry. Okay, so what you will do? You will reduce to 4, 3, and 2 and 1, so that you will get slowly accustomed to it. That is the same concept in delay phenomenon. Okay, slowly you will reduce the blood supply to the tape so that it get used to the ischemia. Okay, and the blood supply from the other areas will try to come into that flap. For example, if you want to include if you want to raise a rectangular flap, you will not raise it completely. You will raise only the distal edge. Then you will raise the other edge. Then you will raise the third side. So slowly what you are doing, the flap which was getting 100% blood supply, first you made one incision. Then you waited for 2 days, then you made the second incision. Then you made the third incision. So slowly 25, 25, 25% you are reducing the blood supply. Okay. So what will happen? Slowly the flap will get accustomed to the ischemia and it might survive. Okay, so in this way you will be able to increase the potential area. You might be able to include the potential area of the flap into the elevating the flap so that it will survive. I think you are understanding. I hope I am clear. So based on this, now anybody can take this answer. Anybody wants to take this answer now? Okay. So you know that delay phenomenon will increase the axiality. So you are reducing the blood supply from all the sides so that it will get blood supply only from its main branch. Okay, so it increases the axiality. And maximum effect is seen after 2 weeks. Yes, it is true. Okay, it induces a hyperadrenergic state. Yes, there are many theories for this flap, means for the delay. Okay, it increases hyperadrenergic state, it causes a sympathectomy. Okay, and it opens up the arteriovenous channels. But the most accepted theory is unified theory, which combines all these factors, and it has nothing to do with the general condition of the patient. Okay, it is done just to include the potential area of the flap into the flap so that it can be elevated without causing necrosis. Okay, so will this delay phenomenon and all, you will not be needing it for a general surgeon, but plastic surgery you might get this. Okay, but this delay is mentioned even in Bailey Love and in Sabiston. Okay, if you see the Bailey law in a local flaps, you will get in the picture alone, you will get a small in a local flap, you will get in the bracket delay. Okay, so it can be asked even in a general surgery part. Okay, if you look carefully, you will be able to find that. Next, this is a very common question which is asked. Okay, as I already told you, Mathis and Nahai gave the classification of muscle flaps. This is a pure fact-based question. Okay, if you know what are all the types of muscles, okay, and you will be able to answer this as simple as that. Okay, general surgery part. Okay, you just have to mug up those. What is type 1, what is type 2, what is type 3, what is type 4 and 5. Okay, and if you know that, you will be able to answer this. Anybody was read this? Nice. Type 4 muscle. Sartorius. Siva. Good, Dr. Siva. Shall we see the answer? So, what exactly is this classification? So, type 1. It's very simple. It's not very difficult to understand. Okay. Type 1 means only one blood vessel is coming. So, there's no question about it. Okay. Type 2, you are getting one major vessel and multiple minor vessels. Okay. And type 3 is you are getting two major vessels. Okay. Type 4 is multiple segmental vessels. Okay, type 5 is one major vessels and multiple segmental vessels. Sir, it looks very confusing. You told it is very simple. No, exactly, it's simple. See, type 1, only one is there. So logically this should be the type 2. Okay, so but always classifications tend to confuse us. Okay, they don't keep it very simple. If they keep it very simple, then it's not being accepted. Okay, so what is this? If you see this, 1, 3 and 4 looks okay, sir. But what is the difference between type 4 and 2, sir? Type 5 and 2. Because here also there is one vessel and multiple small vessels. Here also there is one vessel and multiple small vessels. If you see the name of this will be called the dominant pedicle. Okay, it has only one pedicle, dominant pedicle, minor pedicles. Two dominant pedicles. These are called segmental vessels. Okay, this is called dominant and segmental. So what is exactly the difference between this minor pedicle and this segmental vessel? The difference is you cannot raise this flap. For example, gracilis based on this minor pedicles. These minor pedicles are very small. If you see, they have exactly shown it in this. Okay, if you use these two minor pedicles without the concept of delay, I have told you earlier, unless you ligate this and leave it for some time so that this muscle will slowly get perfused from these two flaps, you cannot use it in a single stage. Okay, but this flap, what's the difference? Sir, here also then what is the difference between these two? Here multiple are there, here two. No, number is not the different. Here, this is the major pedicle and these are all not minor pedicles. These are segmental pedicles. By segmental, I mean, even if you take down this major pedicle, if you raise the flap based on these segmental pedicles, this will survive. But if you base on this minor pedicles, this flap will not survive. That's the difference between type 2 and type 5. That is why this is called minor pedicles. That is why this is called segmental pedicles. Okay, this is only one, and type 3 is 2, type 4 is multiple. So there's no confusion about type 1, 3 and 4. So 1, 2, multiple. Okay, so the difference comes in type 2 and type 5. Okay, you just need to mark up the muscles which are coming in this type. Okay, just you need to understand only these. You need not read all the means or teres major was what type of muscle it is. No. What are the flaps which are commonly done? Those muscles, if you know, it is enough. For example, gastrocnemius, tensor fascia lata, these are all single pedicle. Gracilis, trapezius, type 2. Okay, just if you read this table, that is enough. Okay, for general surgery part. Again, I'm telling you this, that is enough for the basic general surgery part. So what is there extra in the plastic part? Okay, this will be the question in plastic. Okay, which type of muscle is not favorable for use as a flap of all these types? If you want, you can include type 5 also. Now, obviously, you know that that's not the answer. Based on what I have explained, anybody wants to attempt this? Any guesses? I'll give you one clue. Flap means we will want to raise it and move it to another part. It should not be tethered in one part. So I will come back to the picture again. I will see whether you are getting any idea. So type 1, if you this entire muscle can be turned around. Okay, so that shouldn't be a problem. Type 2, again I am telling, this minor pedicles can be taken down and this can be raised based on this. Again, this one, these are two pedicles. It can survive with only one pedicle. So I can take this up to this and I can turn it. Type 5, what I am telling, I can even block this pedicle and I can base it on this. But type 4, since it is multiple segmental, this flap, this vessel will supply only up to this region. This vessel will supply up to only this region. This will supply only up to this. So I will not be able to take down many of these things. Maybe I can take down only one or two. If I take more than that, it will not be enough to perfuse the muscle. Okay, so these type 4 muscle flaps are not the ones which are ideal. For example, even if you see the, where do you use sartorius flap? Oncosurgeons use it to cover the femoral vessels. Okay, only the femoral vessel in the upper part. Okay, in the femoral triangle. Okay, what they do, they just divide it and put it so that they divide only this one pedicle. Remaining everything will be intact. So only it is survived. If they try to remove everything and try to cover the entire femoral vessel from the femoral triangle up to the adductor triangle, it will necrose. So only they don't try to do that. Okay, so this is the applied aspect which should be known to the plastic surgery aspirant. In addition to the what is the facts, they should also know this extra applied part. Okay, that's how we will be dealing with the same topic in a plastic surgical aspect in a different way. Okay, now I'll come to the next point. Okay, I think this should be known to everyone. Okay, lines parallel to the natural skin wrinkles are called Langer's lines, relaxed skin tension lines, lines of maximum extensibility, lines of minimum extensibility. Any takers? Dr. Siva, you have fallen then. Dr. Arvind K. Hi, Dr. Arvind. I had set the trap and you have come exactly into the trap. Okay, Dr. Arvind, lines parallel to the skin wrinkles. Okay, all of us know Langer's lines. Langer's lines are parallel to the skin wrinkles, but natural skin wrinkles. Okay, if this particular thing is asked, what is the anyone difference between Langer's lines and relaxed skin tension lines? Actually, Langer described these lines, okay, in cadavers. Okay, he used to take an ice pick and he used to make a stab incision, a circular ice pick. But the incision will be, means the circular stab wound will get converted to elliptical. That's how we described that. Okay, there is a tension in the skin. It is not a lax structure, it's a tension and it is in a particular direction. And this direction is perpendicular to the underlying muscle. Okay, and this is parallel to the skin wrinkles. Okay, and This is what he described in cadavers, but in humans, means in not humans, in live persons, if you see, these are called relaxed skin tension lines. Okay, these were described by Burgess, B-O-R-G-S, Burgess. Okay, so if they are particularly, if there's any mention like in adults, or if there's any particular hint that it is a live person, then you should go for a relaxed skin tension lens. Okay, that's what I wanted to highlight in this particular slide. Okay, it might look a very simple question. You might think that, yeah, I have written it correctly. Okay, because this point is not given in either Milligan or in your gap or in your Bailey. This is present in older Mathis and in the Converse chapters. Okay, if you read those things, you will be able to come to this conclusion. But this is what the examiners expect when they set this question. This is a particular trap which is very common in many exams. Okay, I hope you understood it. Next, this one. This is a one common difficulty for many post-surgery students. Okay, sir, this flaps, sir, we were telling this is fasciocutaneous, you are telling axial pattern, sir, this is local flaps, or what is this? So what is this? So what is will once you finish this question, I'll explain this in little more detail. Okay, so true about local flaps. If they are raised next to the tissue defect, rhomboid flap is a local flap. Usually it is not based on named vessels. It is generally raised in the subcutaneous plane. More than one point can be correct. Okay, anyone wants to take this? Anybody wants to take this? Dr. Arvind, Siva, Dr. Arun. Okay. So what concept, what idea do you have about these local flaps? As the name implies, it is immediately next to the tissue defect. Okay. Once you see these pictures, this will be a little easy for you. If you see local flaps, this is what you will find in a Bailey. Okay, local flap is raised next to the tissue defect. Basic patterns include transposition, is a flap, rhomboid, rotation, advancement. Sir, what is this, sir? If you see flaps in Sebastian, this is what you will find. Sir, what's there? They are giving so many different types. Here they are telling a random flap, axial flap, pedicled flap, and free flap. There's no mention about those things. So how to come to a conclusion, sir? What's the correct thing? Okay. Actually, both are correct. Okay. For example, there are 6 participants in this session. Okay. So I'm planning to classify them. What I will tell, we can classify them as persons who are Assure means Assure coaching class faculty, and those who are students. In that way, I can classify them. If I classify that, 3 persons will come in Assure faculty and 3 persons will be in students. Okay. So now otherwise how can I classify? I can classify as subspecialists and dental surgeons. Otherwise I can classify as, for example, persons who are wearing spectacles, not wearing spectacles. Okay. So like this, for example, if we see in the same way, I'll be a person who is a Assure faculty. I am a person who is a post MCH, and I am a person who is not wearing spectacles. Okay, so it basically depends on what way you are classifying it. Okay, so if you classify a flap based on its location, for example, in comparison to the defect, if it is immediately next to the defect, it is called local flap. If it is away from the defect but in the same region, it is called regional flap. If it is totally in a distant site, it is called distant flap. Okay. If you classify the flap based on the composition, if it contains only subcutaneous tissue and skin, it is fasciocutaneous. If it contains only muscle, muscle flap. Muscle and skin, musculocutaneous flap. Muscle, skin, bone, osteomyocutaneous flap. Okay, so there are many ways in which you can classify a flap based on the rotation. It can be a transposition based on the movement. It can be a transposition movement or a rotation movement, okay, or a VY advancement movement, okay. So the same flap can be, for example, if I take a groin flap, okay, if I classify it based on the composition, it's a fasciocutaneous flap. Suppose I use the groin flap for a wound in the abdomen, it will be a local flap, okay, immediately next to the wound. Or if I use it for opposite side wound in the abdomen, it's a regional flap. If I use it for a defect in the hand, it is a distant flap, but it's the same groin flap, okay, based on the where is the defect. Suppose I take it as a, whether it is a random flap or axial flap. What is a random flap? Random flap is one which does not have a named blood vessel in it, okay. But the groin flap is based on the superficial circumflex iliac, so it is a named blood vessel. It has a blood vessel which runs along the axis of the flap, so it is an axial flap. It is axial flap, it is a fasciocutaneous flap, it can be a local flap or regional flap or a distant flap, okay. So don't get confused on that. Everything is based on what method you are choosing to classify the flap, okay. So these local flaps, okay, are present immediately next to the defect. So based on the movement, these local flaps can be called transposition flap, Z-plasty, okay, rhomboid flap. These are all based on the movement, whether it rotates into the defect or whether it's advanced into the defect, okay. These are all based on the movement, okay, but these are all local flaps because they are present immediately next to the defect, okay. See these flaps, if you see, if these are not classification in any particular order, okay. If you see, they will be telling it is a random flap. What is a random flap? It doesn't have any named blood vessel or vessel which runs along the axis, okay. See, these are axial flaps, but they have not given that see, it just says that much longer flaps based on known blood vessels. This doesn't contain any blood vessel, but these things are not in a particular, any particular. See, pedicle flap means it has a particular axial blood vessel supply. Okay, free flaps. Free flap means you take a blood vessel, take it to another region, you anastomose it in that region. Okay, so these are all not a particular type of classification. They are just given a random classification. Okay. So if you go by plastic surgery text, then you will know. Okay, based on composition. Okay, as you have seen there, is that plastic. Okay, for a basic general surgical part, what you will need to know, how much is the lengthening which is obtained by Z plastic. It's a very common question. Okay, just if you know the math behind this, you will understand this fact. If the angle of the Z plastic is 30 degrees, this you just have to remember. Okay, I hope you know what is Z plastic. What is Z plastic? Okay, I'll just show you a picture. Just forget this line, okay, just forget this line. This is a straight line. You put Z to Z, okay, and then you elevate, and then you elevate the flaps, and then you close it. This is done to elevate, to lengthen the scar, okay. So when you are trying to lengthen the scar, okay, am I audible? If you are trying to lengthen the scar, so this angle has to be this is the one which we are keeping. It can be 30 degree, it can be 45, it can be 60, or it can be even 90 degree. So if you use that particular angles, you will get a 25% elongation. If you use 30 degree, 45 degree, you will get 50% elongation, 60 degree, 75. Okay, for every 15 degree, you will get 25% elongation. This is theoretical. Okay, and this may not exactly translate it into the particular elongation in the skin tissue. It also depends on the laxity of the skin. So this is a fact which you should know. If you know this, you will be answering this question. But for a plastic surgery aspirant, what extra you should know? Where all will be using this Z-plasty? Okay, the main use of this Z-plasty is for lengthening a scar, for changing the orientation of the scar, okay, to break the scar into small linear parts, and to convert a brittled scar into a depressed. What's a brittled scar? When a scar, when it crosses the concave surface, it doesn't go below and it come up. It just follows a straight line. So For example, a neck contracture, when the wound is healing, it will not go, it will not form the ventolabial angle. Okay, sorry, it will not form the angle in the mandibular region. It will just come straight like this. But you need this angle. So what you will do when you do Z-plasty, this thing will, the scar will get broken. This brittle scar will get converted into a curved scar. Okay, this is what extra plastic need to know, and you might get this picture. Okay, for plastic surgery aspirants, you might get this picture. Okay, the question will be, what is this? 4 flap Z-plasty, 5 flap Z-plasty, rhomboid flap, deformontal flap. What will be the answer? So how many flaps are there in a Z-plasty? For example, if you see only this part, if you see, forget this line, if you see only this is an Z-plasty, how many flaps are there? 2 flaps. This is one flap and this is another flap. Here, how many flaps are there? 2 plus 2, 4. Here, 1 is 5. So this is a 5 flap Z-plasty. If you get this picture in the exam, if they ask what is this, it is a 5 flap Z-plasty. Okay, A, B, C, D, E. All these are 5 flaps. Okay, so where will be using this? That will be the next question. Okay, so plastic surgery aspirants who want to join PGI, you will be having the Viva session. Okay, in Viva session, you will be getting all these pictures. Okay, and they will be asking you, and they will be asking you these particular things also. Okay, they will be asking you where will be using 5 flap Z-plasty. You should not get startled. 5 flap Z-plasty is commonly used first web space contracture release. Okay. So these are all the extra bits we will be going for a plastic surgery aspect. But when we are going the general surgery, when I'm dealing with the general surgery aspect, I will just stop there. Z-plasty, what are the angles? What are the uses? That's all. Those things, if the general surgeon knows, that is enough for other specialties. Okay. Next question. This is pure plastic question. Angles of a deformontal flap. Okay, this is very simple. Unless you know this, you will not be able to answer. This is a modification of rhomboid flap. Rhomboid flap, I'm sure you have seen this in this flaps. Okay, this is given in Bailey. Okay, rhomboid flap means, it's very simple to understand. Rhomboid means the flap is in the shape of a rhomboid. Okay, rhomboid angles will be 60 and 120. Okay, you will get this 60 and 120. So all the 4 sides will be equal. That's a rhomboid. So when you use that pattern, it's a rhomboid flap. This is a modified rhomboid flap, deformontal flap, where the angles are 150 and 30 degree. Okay, this is a commonly asked question. Okay. So what I want to highlight is, these are all common topics. Means like plastic means there are particular topics like aesthetic surgery, these things and all are now common part in general surgery also. Okay, so there are many overlap parts between general surgery and plastic surgery. So we will be dealing for the general surgery to that particular level just for you to answer the general surgery questions. Okay, for plastic part we will be going a little bit in depth. Okay, so that or not even little bit, a little further. Okay, so that you will be able to answer all the questions which are asked in that particular topic. Okay, I hope you got an idea about how we will be going around these lectures. Okay, this is a pure fact based question. Okay, this is I have taken it directly from Sabiston. Anyone wants to answer this? Now Bailey also mentions about microsurgery. Since microsurgery is present in everything, I just wanted to go into next level. So what is super microsurgery? Any cases or anyone knows? Anyone wants to answer? It is exact. Actually, it is 0.3 to 0.8 mm. Okay, more than 0.8 mm, it will be microsurgery. Okay, less than 0.8 to 0.3 mm, because we don't have anything like below the 0.3. It's no, at present we are not doing anything. 0.3 to 0.8 mm is called super microsurgery, and we need 12-0 suture materials for this. Okay, it's usually a perforated to perforate anastomosis or lymphovascular anastomosis. These are all the super microsurgery which is being routinely done now. Okay, I hope you enjoyed this session, and further sessions also will be in this line. Okay, it will not be a pure didactic lectures. Okay, because we have a lot of time. We are the main highlight of this particular model of teaching is we did not cram all these details into your head within a span of 1 or 2 days. We have a enough time so that each topic can be discussed in detail, and you will also be involved in the topic, so that you will not be felt left out. It will not be a pure didactic lectures. We'll be discussing all these things, and you also can give in your suggestions, and you can you can ask your questions. Okay, and I hope you enjoyed the session. And this is just a trailer of what you can expect from us in this teaching sessions. Okay, if there's any questions you want to ask, I'm very happy to answer. Dr. Siva, Dr. Arvind, feel free to ask. I think I've got a chat box. Thank you, Dr. Siva. Thank you, Dr. Arvind. You can give your feedbacks also. Okay, you can give your genuine feedbacks. Do not modify your feedbacks. Whatever you feel, you tell. We'll be able to incorporate those things also in the next sessions to for the betterment of the teaching program. Okay, thank you. If there's nothing further to discuss, I think you can conclude the session. Or if there's any question you want to ask, I'm willing to answer it.